Southwestern Health Resources, where I work, is actually a value-based company, clinically integrated network that is a joint venture between two very large systems, Texas Health Resources, and then the University of Texas Southwestern Medical Center, which is one of the leading academic centers in Texas. And a few years ago, they came together and formed a very large clinically integrated network. We have 5,000 doctors, about 30 hospitals, and 200 to 300 outpatient facilities. And the pandemic has actually provided an opportunity to really showcase and might even be a watershed moment for value-based care organizations like ours. Go to the next slide, please. I'll elaborate on that a little bit. So COVID-19 in Texas, like a lot of places, has hit pretty hard. We've had, although fewer than 1,000 deaths, we have really in the last month or so seen a huge spike up that's really only now plateauing off. And Dallas-Fort Worth has roughly had up to 2,000 hospitalizations a day, up to daily deaths of about 20. Again, that's plateaued somewhat, but you can see it's gone up quite a bit. Go to the next slide, please. The pandemic itself on the health of our community has really seen a huge impact on clinical volumes and access, hospital avoidance. We've seen a lot of spikes in death at home, and I'll talk about that in a little bit more. And the parent organizations until recently really deferred ambulatory, I wouldn't call them elective because they were non-critical, a lot of those cases, because we try to keep capacity for our ICUs. We have since balanced that out now where we're close to probably 90% of where we were at post or pre-COVID. But that's also allowing for things like social distancing, and a lot of the volume we have now is catching up from those 3 or 4 months of not having ambulatory and elective surgery. This had a huge impact on ongoing quality metrics and screenings. Again, we've seen at least a 30 to 40% drop in people getting required screenings like breast cancer screening, colorectal, things like that. And it's created a real challenge for us to try to make up. There's been a large impact on undiagnosed cancers. There was a research done by Epic with a number of their providers that have Epic EMR systems. Up to 90,000 people avoided getting cancer screenings, and up to 20,000 people do have cancer that has gone undetected. So a huge amount of impact on people avoiding care. And then there's also challenges around coding, a lot of pivoting to telehealth, for example. How do we code that type of thing? We've seen a huge shift in people going, a lot of individual practices. We have about 2,500 community doctors that did not have telehealth pre-COVID. Now all of a sudden we pivoted and we see them bringing telehealth into their regular practice. Next slide, please. During the pandemic, like I mentioned, we saw probably almost an 80% drop in patient visits among a lot of the independent practitioners that make up our network. To help them get through this, we actually accelerated incentive payments for third quarter, fourth quarter, et cetera. That infusion helped keep those practices going. We really reached out our physician value proposition, one of those things being pivoting them to telehealth, and that included teaching them how to tie it into their EMR, as well as how to code it properly. As a result, we probably had 4,000 to 8,000 more visits per week than we had in the past, going from maybe 10% of the doctors having telehealth now to now 100%. We have seen some increases in network efficiency. Just as a result of having to close gaps, it has caused us to look deeper into our patient database. How do we reach out to those people and then engage them either in personal care or even virtual screening? So a lot of technology has actually been enhanced by this whole process. And then beyond that, how do we reach out even in person to reaching those shut-in high-risk patients that maybe would avoid care otherwise? So now we're focusing more on reaching those high at risk and risk cases as a result of the pandemic. Next slide, please. Like I mentioned, a number of the things that we did to provide support to our providers. We've not only been working with them on regular care, but also post-acute. We've really reached out quite a bit to skilled nursing facilities. We've actually tiered our facilities based on compliance and quality and service. And now we've actually tightened that up, done a lot of COVID training with them through our medical directors. So it's actually had, across the continuum, has actually benefited the overall quality of care that we're providing the patient. Mentioned before too, we're doing a lot of things with EMR, trying to tie those notes into telehealth. And then we're also exploring virtual scribes to help doctors do their entries to EMR. Next slide, please. This is just another way, this helps envision what we at Southwestern Health Resources do. Our number one client would be physicians. And so we're trying to expand out the type of services that we're able to provide to those physicians, not only to close gaps, but this one slide, if you look over in the upper left blue, go back, actually go to the next slide, Chris, that would be fine, because some of this is listed out. On the very bottom, there are a number of tests that we're working with vendors to do at-home mailing so that people would do Cologuard or diabetes screenings at home. So we're working on relationships with those vendors to send those out, collect, and expedite the processing of those screenings. The difference here is this is a benefit to gap closure. And these are non-COVID cases, but because people are more reluctant to go into the physician offices, it's making us think of new ways to reach out to them at home to get their screenings done. And again, that ties into database information, emailing, a lot of different type of outreach. And again, because of the surge, as Chris showed before, we've seen a huge uptick in people opening email as a result of this. Next slide, please. Go one more, please. So I've mentioned a lot of the outreach that we've been doing. I want to go through a series of examples that show specifically what we've been doing. In the Dallas-Fort Worth area, we knew that we had about 100% increase in death at home from the start of COVID year over year. This was a huge concern for us because we knew people were dying, particularly of things like stroke and heart attack. So we did a mass mailing, and as a value-based care organization, we're able to identify of the 700,000 covered lives that we service, how many of those people were at risk, diabetes, high blood pressure, things like that. Taking that information, and we did a direct mailer in both English and Spanish to more than 200,000 at-risk patients. As a result of that, and putting them in touch and coordinating care with their individual physician offices, they would call their physicians or they would call 911. And as a result, we saw at least 45 traceable cases of people that either gone into an EP lab or actual open heart surgery as a result of that mailer. Some of that was manual tracking, but at the same time, we're able to look at charts and figure out who actually came in as a result of that. And like I said before, these mailers had about a 60% open rate, not just the 40 to 50%. So it's huge impact. I think part of it is also knowing us and who will be reaching out, because we'll tie the physician, their personal physician name to these different emailers. Next. The next thing that we're doing is to try to reach, I mentioned before, the high number of cancer patients that are not getting screening. We're now doing similar to what we did with heart and stroke. We're now reaching out to women and men. So we'll divide the types of cancer screenings that we're trying to do with a series of mailers that are going to be going out. This is the first email that's going out. Based on their feedback, we'll either track them to do an appointment, or if they don't respond, we may do outbound calls to follow up with them. The next, if you go to the next message, would be one for men. We were trying to break this out into 6 different types of mailers, but what we find is when we look at the information that we have on our different patients, a lot of them have comorbidities. So females may have both breast and cervical cancer risk. Men, it's going to be basically colorectal, which is this is our top screening that we're going after as well. Go to the next slide, please, Chris. We're also doing diabetes, which again, these are 6 or 7 chronic conditions that are at the top of our list, which also match CMS guidelines. So we have really expedited this process. Again, we're partnering not only with the direct mail, but we have vendors that do labs, that do the different testing, that where we can do things at home, we're doing that. And this is going on right now. So we will close the gap and measure at the end of a 6 or 7 week period to see how the outreach performed. The other thing that we're doing is we work with physicians that send out the letters. We give them a list of their patients that are at risk, and we're having the physicians actually do outbound calls to their patients to try to get them in to come into the office. And again, as we track that, it'll end up being manual chart review to see how people did as far as responding. Next slide, please. This is an example of the phone script that we provided to the physician's office. It's hard to read this, but we also created scripts to provide to the physician offices, again, thinking that the patient will respond better to the name that they know, which is their doctor, than it would if we did a cold call coming from Southwestern Health Resources, which they may or may not know. Next slide, please.
Hey, Greg, actually, there's a question that came in from the audience
Sure.
that was addressed earlier. So you had mentioned personalizing mail pieces. Could you define or describe what personalizing actually means in this context?
Sure. So I mentioned before, we're able to match the patient with their physician, and probably 90% of people have got a primary care doctor. So you take those names and then you match it with the physician. The letter that we send out, email, in some cases we'll use snail mail, will come out from that doctor to their patient. So we can do that mix and match sorting based on the information that we have on the doctor assigned to the patient.
Okay.
So that's the personalizing. And then the other level of personalization is those patients that are at risk for those types of cancers, heart, whatever it might be. So we can go a step further as far as identifying those patients who are at risk. The other thing that we did, obviously, is you want to support everything by website. All of this material, we've created a website where we have all that information that we've sent out, but we're always updating it. So right now we have a big campaign going on, not only at Southwestern Health Resources, but with our parent organizations, trying to get people to come back. Again, we see 30%, 40% people that have cancer, heart risk, whatever, are afraid of going back to the doctor's office. They're afraid of going to the emergency room. They're afraid of going to an ambulatory center because they're afraid that they're exposed to COVID. So we're doing everything that we can through, again, working with physicians, putting out digital campaigns, SEO types of things to try to get people to allay their fears that it's safe to come back. And so this would be just tips on coming back to your physician office. The final slide is the one that has just launched actually today. And this is one that we're really very excited about, where we're partnering with doing PSAs, but we're also working with more than 600 nonprofit agencies like churches, schools, etc., primarily trying to reassure people that it's safe to come back to the physician offices. Particularly important for us is the Spanish language population, because they are 4 times more likely in our market to have COVID. We also see that they're probably in the greatest need to be reminded to take those precautions, wash your hands, wear a mask, socially distance. So we're working with Univision across multiple platforms. Univision and their network reach about 70% of our Spanish language population in the Dallas-Fort Worth market. So we've embarked on an education campaign, working with them, online personalities, getting our doctors out, having web-based discussions, community forums, things like that. And again, now we're working with schools, Catholic Church, Methodist Church here in North Texas, try to get them to share information. In the old days, you mentioned my 20-year career, there's nothing really new under the sun. You just use a different platform. Working with churches is very similar to what used to be called the parish nurse program, where you would have a nurse that represented a Catholic parish. We would work with them to educate people through their churches. So now we're doing the same thing. It just might be virtual, or we're using their websites to download information. So we're really excited about how this might transition. For us, long-term, if this goes well, again, a lot of what we're going to be doing will be working on social determinants of health, getting information out to start not only doing preventive care, but we're going to be looking at trying to use AI to start pulling in big data and do what we'll call anticipatory care. We're able to look at somebody's family history, predictive modeling, and start getting that information out, working with the patient, working with their physician to try to get them to live more healthy. And how do we come up with ways for them to use other things? And again, if it's a underserved population, how do we help them with food, transportation, things like that to have a healthier lifestyle?
Greg, first of all, thank you for sharing. Thank you for presenting metrics that could be sensitive to the health system and the population, everything like that. We all really appreciate the transparency. And I'm just seeing from the audience, there's a lot of excitement and interest in what you will be doing with the AI and big data approach. So we're excited to get back and get deeper into that a little bit later in the conversation. Now, to shift gears a bit, I wanted to introduce everybody in more detail to Walter Groszewski, because he's got an exciting background, exciting career as well, which has been on leading large healthcare related initiatives. Got his start within a healthcare division in IBM and has worked with systems like Oracle, MedSphere, just basically bringing a really rich background in change management and in healthcare technology. And now the current focus, if you've seen some of the content, the white papers that he's been putting out on establishing that patient 360 experience, we're really excited because he's able to talk kind of at a broad national level on a lot of the health systems that they've been enabling as a Salesforce partner at Silverline. So Walter, we're going to be speaking heavily on this 360 type ecosystem, and I know you've written a ton about that and how it relates to intelligence-oriented outreach. But I still feel like that might be a little bit nebulous to people. That like, what exactly is the patient 360? How does it relate to the things that are going on today? So could you give us just an overview on how this works out or shakes out for clients?
Sure, absolutely. Thanks, Chris, and good afternoon, everyone. And you know, it's a privilege to be here talking to you, and thank you to all the clinicians and Greg and his team, and you know, for kind of being on the front lines during this time with COVID. You know, we would never have been able to get through all of this, and we're still in the midst of it, but thank you for all your hard work and commitment. You know, specifically to Patient 360, you know, in its simplest form, it's really aggregating the necessary data for you to interact with your patients or consumers. They don't have to be patients, right? They may get to be a patient within your organization, to be able to have an intelligent outreach and communication with them based on their conditions, based on their history. It's interesting, as Chris mentioned, I've been around this for about 25 years now. When I worked at IBM, and I want to say back in 2005, you know, we didn't call it Patient 360, we called it patient-centric networking. And just to date myself a little bit, you know, the original start was when, you know, all of the hospital systems out there just had the ancillary systems, right? There was no EMR, right? And everybody had to kind of figure out, depending on what system they were in, who they were talking to. Is W. Groszewski, WJ Groszewski. And then, you know, we went through the whole, you know, regional health information exchange and really trying to drive towards a longitudinal patient record. So we had normalized data, cleansed data, and uniquely identified data about patients. That's kind of where we were at IBM. You know, our ultimate vision was, you know, applying that data and that engagement and those interactions at that time was really more around clinical where you were sitting in a hospital room, or you're sitting in your physician's office, and applying the knowledge that that clinician was learning back into the system, so to speak, so that we could start mining that data from, having better interactions with patients, whether they be direct or whether they be via, back then you would never even imagine, some sort of automation for engagements with patients. So, Patient 360 has evolved. Today, it's really about having the necessary data to intelligently engage with patients based on their history, based on their preferences, based on social determinants of health, based on their behavior. There's a lot more to it today than just clinical information. So it's really providing that foundation to be able to outreach to your patients and your consumers. Could you go to the next slide, Chris?
Yeah.
So, I just wanted to take 2 seconds to take a step back. And, this is our perspective about, we're really seeing an acceleration. I mean, change is happening nonstop in the healthcare industry for the last 25 years since I've been in it. Not only technologically as it relates to medical insights, but also technologically as it relates to information sharing and those kinds of things. And, our perspective, if there's a couple of macro trends that we see, to be quite candid, capitation, value-based care wasn't a C. So we had to find a word with C to come up with the 5 Cs. But it's basically, if you think about how intelligence is needed in the data, you think about, as Greg was talking about before, value-based care and having insight to your patients, but not only your patients, but also the ecosystem of providers that are out there in your network, right? As a hospital, your ambulatory surgery centers, your physical therapy organizations, your primary care docs, who's providing the best care at the best cost, at the best outcome. It's really about managing the data about the patient as it relates to that and engaging them at that level. Consolidation, you think about it from the perspective, Greg mentioned that he's a clinically integrated network. Well, we've worked with systems who are consolidating, local systems. Think about the information that they both have potentially about you as a patient, right? How do they merge that information? How do they not duplicate that information? How do they streamline those interactions? Coordination is really about the ecosystem and the management of the information about your patient to provide the best care, whether it's you as the institution or whether it's whether you're a primary care provider or whether you're a specialty provider, which is becoming more and more prevalent nowadays. And then finally, consumerism. Think about, for example, the impact, for example, around retail healthcare. It's, certainly patients, consumers, members want better service from the healthcare system, from the same kinds of, going to a pharmacy, going to, a Kroger's. They want that kind of service. And, think about, how you can leverage information to intelligently engage your patients. One of the unique things about some of these retail clinics, my older son is 30 years old. He does not have a primary care doctor. He goes to an urgent care. He has gone to the Walmarts of the world because it's convenient. It meets his time frame. The challenge is they don't have all the information about him to properly engage him and make sure that he's delivering and is receiving the best care that he possibly can. So these are kind of some of the macro trends. Go to the next slide, Chris. And, now here's the 6th one with COVID. Think about in addition to the stress that it's put on the hospital and the healthcare system as it relates to PPE, as it relates to, beds, as it relates to all kinds of activities that the healthcare workers are dealing with, as well as the patients. But, think about it from an information perspective. It's been really enlightening to us. We've had several clients that we've worked with, and you think about Patient 360 and all the information and really having a comprehensive view of that patient. Now, what do you do? Well, we've had several clients that have actually taken that step earlier on and actually have been able to bring that view together. One happened to be a very large urgent care provider. And, one of the things that Greg mentioned is people are afraid to come back, right? So, or even to show up. So what they did is, because they had a view of all their patients, they were able to outreach to them, explain to them what's going to happen from a process perspective when they show up at their facility and what's going to happen when they leave their facility, right? If you didn't have the foundation of Patient 360 there, you would have never been able to engage those patients to kind of allay their fears a little bit in terms of we are in the midst of a pandemic, but we have instituted procedures for your safety to make your visit to us, a fruitful one. Another organization we dealt with, or additionally, they're a large physician practice. They had also put the infrastructure in place, and they were able to reach out to their at-risk patients very specifically to really, for a couple of reasons. One was they had patients who were showing up at EDs, and they didn't know what to do. Now that I left the ED, they were scared to come back to the physician's office. So they put communications out very specifically to the at-risk patients. And then, the second thing that they did was really, as we saw a major uptick on telehealth, the growth in that from a process and technology perspective has been enormous. They outreach to them from a telehealth perspective to say, we have alternatives for you from a care perspective if you don't feel comfortable coming in the office. And then finally, I think Greg mentioned this as well, we've seen a lot of clients who, okay, all right, Texas is maybe spiking up a little, New York is tearing down, and Northeast is tearing down a little. We're seeing a lot of clients thinking about, how do I get back to semi-normal, right? How do I re-engage those patients that should have had their mammogram, that should have had their colonoscopy, that have not been coming to our facilities? How do we re-engage them? And, pretty much looking, that's a scheduling problem, right? Taking a look at all the canceled scheduled appointments that are out there, prioritizing them, using intelligence to say, which are the most important clinical procedures we need to have patients come back for. They may not be life-threatening today, but we all know that if you don't take care of it now, something else is going to happen at a later point in time, and it's just going to pile on, right? So the cost to the system, the impact to the patient's health is just going to complicate itself. So we've seen that Patient 360 kind of engage patients from a variety of perspectives across all of these macro factors. And, probably most of you in your organizations, I'm not going to show, this is kind of some of our experiences of working with clients for the last 7 years in around patient engagement. But just a couple of them, I probably ring true to maybe a few of you. The first one is single source of truth is a moving target, right? We need to make sure we have the right information about that patient, because we will make a mistake or we will miss some care that should be delivered if we don't have that information. Another one that we've heard over and over again is, we take good care of you when you're here, not before. And I'll talk about this, right? Systems have evolved from a data perspective. I mentioned it was, just the ancillary systems. Then we moved to electronic medical records. Now we're moving to a digital transformation, CR client relationship management perspective. So, the EMRs have done a great job addressing the care of the patient when they're in the room with them. But, once they leave, before they show up, after they show up, how do we continue to engage them to make sure that they're getting the service and the help they need, and they feel comfortable and safe with our organizations? The last one I'll hit on this page, which I love, we actually had a couple of examples. A patient can get 8 different communications for one visit. This is the whole concept, and I'd be lying, we didn't create the term. I forget which organization that we worked with did, but the whole concept of a medical mom, right? I take care of myself as a patient, as an individual. I have 3 children that I need to coordinate care for. I have parents that I probably am coordinating care for, and I'm probably also coordinating care for my husband as well. So, an intelligence system would recognize that you are the caregiver or the medical mom for all of those individuals. It will notice that you have 8 appointments in the same day, and rather than share 8 contacts with you from an outreach perspective and confusing the individual, we can consolidate that, because we know you're all part of the same family, and we can outreach to you from that perspective to make sure that we're providing the best service that we can. Next chart, Chris. So I mentioned this, and I'm not going to spend a lot of time on this. There was a time, I think, when you think about the information that's driving Patient 360 and the engagement, the electronic health record is the foundation for that information, right? And in the past, many people would have maybe said it was the electronic medical record versus the customer relationship or digital transformation solution. We believe that they work hand in hand, and they each provide certain value and certain outcomes. If you heard Matt Gretzko talk last week, right? It's all about the outcome. They'll provide very unique capabilities to achieve certain outcomes that you're going to want to leverage. So part of the challenge, we think, is in that journey that you all are taking is, what's the right time? How do you transition? What data belongs in your CRM versus, obviously all the core data and the source of truth data goes in your EHR. Next chart, Chris. And this is just a little reflective to try to show the variety of systems. I'd be lying if I said that was every system that exists on the left-hand side in terms of where all that data comes from. But, you know, part of the importance of intelligence and insight in the data is, yes, we have to cleanse the data. I think technologically we've solved that problem. We've actually been able to bring the data together about the patient to uniquely identify them. So we make sure that we've got comprehensive view of the information about the patient. But now is where the fun comes in. Right now is when we were talking about patient-centric networking back at IBM, this is where we didn't have the insights to actually drive engagement, right? So now that you've got all that information about the patient, now you can start leveraging that information, not only that's coming from the variety of systems that are in the healthcare system, but now starting to apply also things like consumer behavior, social determinants, applying machine learning algorithms to drive insights so that you can better interact with your patients, whether you're in your patient engagement center, whether you're using a marketing automation platform or a social engagement platform to reach out to those patients. And typically what we see from a vision perspective as it relates to you know, intelligent digital transformation and patient engagement, it's, you know, and I think Greg mentioned this, it's not only about the patient, it's also about the physician, right? Because you'll see in a second that they're critical to everything here. You know, your patient engagement center, you know, your patient engagement in terms of digital outreach, you know, how are you going to engage them from a service line and specialty perspective? You know, we mentioned gaps in care and, you know, the fact that, you know, reaching out to diabetics, how can you leverage the information to target those diabetics, communicate to them that, you know, you have not been in for your eye exam, which is a major gap from a diabetes perspective, or your A1C or your blood pressure, you know, typically the major factors. How do you use that information from an insight perspective to outreach to those patients so that you can bring them in and treat them accordingly? Next chart, Chris. And I think this is my last one. So, you know, this is kind of, you know, how can intelligence help you drive that digital transformation within your enterprise? You know, we always talk about the patient, and the patient's certainly at the center of the chart, at the center of the circle as it relates to care. But if you think about it for a moment, the number one dissatisfier in almost every survey I've ever read about healthcare is scheduling, right? And you can't schedule as much information if you have about a patient. If you don't have the right information about the providers that service those patients, how are you going to appropriately schedule them? How are you going to appropriately refer them, right? So it's a combination of dealing with the physician's relationship management, the patient, and then, you know, how do you engage, whether it's a loyalty journey, whether it's a gap in care journey, whether it's patient reminders and follow-up, whether it's something like intro to our health system. From an outreach perspective, they're a new patient to your system. How do we engage them? And then finally, from a chronic care and transition management perspective. So, you know, from our perspective, this is how intelligence and Patient 360 kind of come together in a digital transformation roadmap. So that's kind of my intro, Chris.
Well, hey, great intro because it helped make it tangible for a lot of people in the audience. And we've been getting some questions that are related to this too, especially how this impacts your ability to deliver customer service, or how to target certain programs that might benefit people who might be suffering from various conditions, like even social conditions like unemployment. So look forward to digging in our panel time with that.
Thank you.
A final introduction for Sheetal Shah. He's our Chief Operating Officer, and he's okay. So you've got the screen, perfect. So yeah, he's our Chief Operating Officer with a great background, leading digital transformation at top 10 organizations across the country. And Sheetal just wanted to take it for like we built up on Greg's experience, and then the Patient 360. Walter introduced this concept of AI and machine learning, and really just wanted to kind of like take that into some use cases that are tangible, if you have some thoughts on that.
Yeah, absolutely. And I loved the Walter's last graphic with the prior one with the halos. Really speaks to the role of AI. But maybe I'll start with what artificial intelligence isn't in healthcare in terms of what we're talking about today, right? We're not here to talk about replacing physicians. We're talking about how do we use massive data sets, though, to find insights and make decisions on what would take humans years to do by themselves. In our case, we're talking about outreach, right, and engagement. So what I wanted to share was, let's establish the role for AI in healthcare, right? And if you look at all the research that's out there, that's being published at a feverish rate, there's also a flip side of not only how healthcare models are changing and the requirements we have on why we engage the community, patients, families, and caregivers, but also the provider side and how much burden we're shifting to them to take on the role of engaging the right people at the right time for the right things. So if we looked at, in the US, they say the typical primary care, I think average panel is 2,300. I've seen it go as high as 2,500 patients per PCP. If you just looked at that and you asked a PCP to basically provide all the recommended acute, chronic, and preventative care, care itself, but then also the engagement to get the individual in the door, they would be spending 21.7 hours a day working. Let's settle in for a moment. You basically are asking an individual to provide the acute, the chronic, the preventative care, as Greg said, the anticipatory care ahead of time, and getting, that's just obviously, this type of engagement just does not scale. So when we talked about sort of where we are today, I in prep for this last week, I posted a quick LinkedIn survey, just like, hey, you know, how are you being engaged by your healthcare organizations, your PCP, the health systems that you're part of? And I think about 88%, and this is not a scientific study, just an informal survey I did on LinkedIn, really felt like they engage you in a generic, or sometimes it's even completely absent. And so I was really interested by that fact, because we're starting to see a ton of disruption in this space. And what is disruption? Disruption is outsiders coming in to do something better than others do in a transformative way. And so I look at some of the stuff that's coming out, and I think Greg's example at Southwestern Health Resources is a step in this direction. We look at One Medical, right? And we look at their sort of terms of service, and I went through the 30 plus pages, and I found this section, and it basically calls out, hey, in many ways, our role is to be the purveyor of health information to you. And we may use your data to inform what we tell you. And by the way, we're gonna reach out to you by email or phone or whatever preferred method you have. So if you look at it, we know the ability for providers in a typical model of healthcare to scale engagement is not possible. They're already slammed with that 21 hours a day if they wanted to do everything for everyone. We know that today it's not personalized. If anything, that engagement's absent. And then you look from the periphery and you're starting to see organizations look at, hey, we found the hole that we're going to plug. We're going to form a strong relationship. And so, Chris, when we were talking about topic titles with Walter and Greg, I'm like, would people be offended if we said we're talking about intelligent outreach? Like, was it not intelligent before? And I don't think it wasn't intelligent. I think the outreach done before was there was reason behind it. There was thought. There was teams that came together with, what do we say? When do we say it? But we're in a new era. We're sitting on a treasure trove of data that allows us to do things that are scale. And I think that's the piece that when we say intelligence, it's at scale. It's at scale on how we personalize the communication, that it has purpose for both the patient, it's relatable to the individual, that they actually will open it and read it, right? It's proactive. It's about forming a relationship. It's about, hey, I was thinking about you. And I like the example Greg said, which was, if we're going to be proactive, we're going to personalize it too, but we're going to put the provider's sort of a branding on it, because guess what? There's trust there, right? So it's proactive and it's prioritized, because again, you could try to slam every bit of what you're trying to do with the individual, but it doesn't work. So how do we work in a very sort of structured way, that every time we have a touch point with an organization, and I was looking at what a mid-sized health system would have from the number of touch points they would have with a consumer being a patient or a patient they'd like to work with, have It's like 33 million digital interactions. Now the question is, how do you make those 33 million digital interactions personalized? How do you become proactive? How do you prioritize what you engage an organization, individual on? So I think with intelligent outreach, it starts doing something that's more important. It's the start of a dialogue, and it really helps you activate a relationship. Now, I think I've said a lot of things and sounds a lot of, pie in the sky, a lot of things we'd love to aim for, but how do you actually do something? And so, one thing where I'm coming from is, as Walter said, we have spent the last few decades, especially the last decade, actually amalgamating, getting sort of access to data. Now you have to go through the process, and that's where we at Symphony have been spending our last 6 years, is basically identifying from that data sort of this brain concept. And it's like, hey, if I had the opportunity to engage with any given individual today, what is the activity, what is the action that's the most important to actually influence the consumer's health behavior? We saw how Southwestern Health Resources is trying to act on the fact that there are individuals today that have high risk for cancer or have likely had an AMI event, but had deferred going in. So how do we identify for every consumer, what is it that we want to say? How do we reach out to them in the right channel and then track activity and accomplishment? And so if we look at that mid-sized health system, 3 hospitals and the like, 500,000 patients that you're engaging, and we look at those 33 million interactions, like how do we make it intelligent? Well, it's probably putting at every point of interaction that bit of data that informs what you should be talking about to achieve the metrics that you want. And so as we see in the ecosystem, a number of technology vendors come into the space of, hey, we have AI, right? We have AI to help you engage consumers, to help you scale the role of the provider in terms of in community and population health. I kind of wanted to share sort of what healthcare leaders like those that are on the call should be thinking about when they're talking with vendors and others in the space. And it sort of comes down to these 3 buckets. One is around transparency and fairness. So as you start designing and using AI to make decisions on how you engage, thinking forward, you really should be asking, how transparent is this partner or vendor that you have in the way that they've designed their models? We hear a lot about, we have hundreds of models and the like. Well, is it transparent? Can you explain it? There's a whole concept of how well can a model be explained. Say one says an algorithm for breast cancer detection. Well, what patient characteristics were used in that? And so there's elements about transparency and fairness that basically need to be asked, right? And to prevent sort of that black box concept. And we're seeing now that the model's only as good as the data it was trained off of, right? And so the data that it was trained off of, were there instances of unintentional bias related to race and gender? So really push yourself with the vendor and partner community around these questions, especially as you start leaning on AI to help scale engagement. Second area is modeling. I think any properly equipped research team will be running hundreds of thousands of experiments to predict outcomes. So ask these vendors, what kind of experiments are you running to predict outcomes? Are you using neural networks or tree-based models using, XGBoost or random forests? There's a lot of different approaches to solve for the problem. So you have the opportunity to ask how these models have been built. And then obviously one of the most important elements is then the performance and accuracy. It is okay to ask, what are some of the target variables it's solving for? What is the overall area under the curve? What are some elements around false positives and the like? So as we talk about the role of AI in healthcare, around the role that AI has with scaling the provider's job of engaging a health community for the right reason to drive outcomes, reduce total cost of care, and the like, really, as you start working with different vendors and the like, this is probably some of the core questions you should be really asking them for. So to give you an example, when we go to market, we kind of share the same story, right? That, you know, we're looking at tons of data across the board, from the EMR to claims data to population health data and the like. And so say, for instance, for Judith Smith, we may have identified, hey, this individual actually has high risk for breast cancer. And what we want to do is engage them. This platform wants to engage this individual to get that mammography. And we're going to engage by email because we've shown that this individual has a channel preference for it. So while other, you know, models that are out there might say, you know, their AUC is, you know, like the Tyrer-Suzak models at 0.786 or the Gale models at 665, you kind of have to ask, you know, when we go to the market, we're actually presenting our AUC is 0.852 and it's 3.5x better. And these were the key features that the model found in scoring this individual and the population. So these are the aspects when you talk about AI-driven patient engagement. Ask for this. This is what actually sets you apart as you start moving towards deploying technology like AI. We spoke a lot about the provider side, and I think Greg mentioned the physician side. One thing I'll say is that if you were to look at your provider liaison or your physician liaison team that's out there having their thousands of conversations a month, here's a real world example. It's a bit it's a sneak preview of what's going to be presented at the Healthcare Strategy Forum in the coming weeks, that basically looked at what are physicians saying in our market. And so on the axis that you have here on the bottom, you see pre-COVID. There were a lot of questions around dermatology or questions about phone numbers, insurance, you know, questions that physicians may have that were pulled from a note that a liaison took. On the axis over here, you're seeing what are physicians saying now? What are they asking about? And you kind of look at the higher you go, it's the more frequent. You'll notice that instead of asking about, you know, location data, times, dates, they're asking about, for instance, antibody testing. They're asking about questions about, is there curbside testing, because their patients are asking. So this is where AI has a role in physician engagement, where you're able to look across the board in near real time and see, hey, look, this is what our community of providers is actually most interested in hearing about, which then can help craft the marketing and communications tactics and outreach. And again, it's intelligent outreach. It's personalized to what the community is asking for. You could prioritize it based on how often they're asking for it, and allows you to get proactive and get in front of it. So I'm going to end with this shameless plug. We spoke a lot about patient intelligent outreach on the 20th Intermountain Healthcare, and Chris, our facilitator on this webinar, will actually be speaking about how outreach, how you can get into the game of being a data scientist as an outreach representative and look across, in this example, 17,000 notes that have been taken in 2 minutes to make sure that you're basically personalizing the engagement that happens with physicians. Chris, I'm going to stop there.
All right, fantastic. Thank you very much, Sheetal. Actually, thank you everybody for the introductory presentations. We're actually getting close to the top of the hour, but we wanted to get into some of the questions that were coming in from the audience. So thank you for taking care of those. So if anybody is curious about what's going on in the Q&A panel and some of the questions that people had of the panelists, you can click the Q&A button at the bottom to get those perspectives. And in addition to that, Greg, I think you got a question from Shivani Chadha about outreach to Hispanic populations. So I saw that you were planning to answer that live. Did you want to go ahead and?
I'll be glad to do that live. I also did it online, but in the chat box. But no, really, that's a huge part of what we're trying to do. And again, some of it's opportunistic. Some of it is about leveraging the current COVID situation to work with Univision on PSA type of approach. What's nice about them is they have so many different platforms, radio, TV, web-based chat, stuff like that, to get our physicians out to talk to the audience. And these are all Spanish-speaking physicians. But what's nice is they've also opened up a lot of their top on-air talent, which a lot of people have. They're trusted people. They're followed a lot to help us reach. I think the other thing that we're really working on is working with trying to meet the population where they're at. So that could a good place to go would be church. A lot of outreach going on through the Catholic diocese. We actually have a very large Hispanic population in Methodist churches. So we're partnering up a great deal there to provide resources, but also if there's opportunity again online using their web platforms, their social media, et cetera, to get our information out. The information is branded, but that actually tends to be something that people trust. Oh, we know that name, we know that name, we know that doctor, that makes sense. The other place that we'll spend a lot of time will be working with schools. And we're seeing this not only, and I've only been on the job about 6 months, so I would have done this earlier had I been here longer, but we also want to engage those relationships in other longer term things like screenings, prevention, and then we're going to reach more and more into social determinants of health. And again, some of that will actually be driven by the big data that we have. We can pinpoint zip codes where people live that have a higher concentration of different ailments, things like that. So that's where we're going to match data plus need, but getting even into grassroots, because there's still that personal relationship that we never want to lose sight of. So it's an ongoing process, but hopefully through those partnerships, multimedia channel, in-person types of things, we're really hoping to make some inroads. And then as we have educational programs, roll those out through the different nonprofits. So it really becomes much more of a community-based approach, which is really what I think is the idea behind population health.
Excellent. Yeah. Thank you, Greg. You've presented a holistic view on multiple points of outreach, including the fact that, hey, we have this AI and data science in play, but we still need to understand how to reach out and be in the community, the population that we're trying to reach out to. Really, we only have time for one more. So I thought I might throw this one over at Walter. And if we do go over, thank you very much for spending a little bit more time with us. But Walter, a big reason that we've seen digital transformations fail is because people aren't adopting the new process or the technologies for the change for the needed change. Could you give us some highlights on what successful change management strategy looks like?
Sure, absolutely. A couple of things, and I'll try to be brief. So, first of all, it needs to be part of the process from the beginning. A lot of times we see people try to push it off to the end. It's where we know we need to do this, we know we need to do this, but you do need to start thinking and incorporating the fact that you are changing your operations, and you need to have a plan for how that's going to be successful. I think what people forget is people drive change. Technology is not going to drive change, right? It's the people. So, you really have to, establish a champion, right? And establish the team, make sure you're engaging the appropriate stakeholders as part of the process, because that's critical. You're not going to drive adoption without really focusing on that. And then specific to the change plan itself, you really need to think through a couple of things. You need to think through your communication strategy in terms of outreach to the organization, because it's not just the people. It's just not the people part of the project, but it's the broader organization. So you need to think a little bit about what's the messaging, what's the purpose, when are we going to do this, right? Don't do it too soon because you might not have results. You have to really be a little thoughtful as it relates to that. Training is certainly key to adoption of any new technology, process, whatever that is. And then, the last couple of things are, don't forget once the project's done and you've managed it to gather feedback, right? Because nothing's ever perfect. You have to continually reach out to people. You need to monitor the outcomes. So you need to have a way to track success. And then, finally, I think you need to celebrate success. I mean, you know, change is never fun, right? Change is always scary. And I know this, excuse me, it sounds stupid, but, you know, the simplest little things in terms of achievements can really keep a team going and keep a team, an organization driving forward to push for the adoption.
Thank you very much. And Greg, do you have time for one more? There was one that came in that I thought would be good for you to address.
Sure, thanks.
Okay, so so Sheetal presented various use cases for artificial intelligence, and you brought up some things that you guys were playing on. Curious if what you saw from Sheetal's part of the presentation was in line with what you're seeing health systems use, how you're seeing them use AI.
Oh, I absolutely. I think that Sheetal's spot on. I'm going to kind of borrow a little bit of something that Walter was talking about, but that's going to be critical, and that is the preparation and lining up and thinking through things. I mean, for example, compliance, personal health information, protected information, HIPAA. These are probably the biggest hurdles that we have to think through. And it becomes very complicated. For example, if I have health information from claims data coming from one health provider, I cannot share it with another one. And there's so many layers of legality that we really have to think through. We've actually launched a special multi-layer compliance program where I work, just to make sure this area and this area realize that you have to be careful. There may need to be a firewall between those two. And think about it, compliance and legal, actually they're my best friends. And again, going back to what Walter was saying, bring them in early, because it's going to be really important. It's the same thing. If you put in some kind of information where you're just serving up content to somebody and they're starting to get information that's really personalized, it's almost Orwellian. When some of that information comes in, it'll scare people. You know, people, it's weird. If you do it for them, they become very protective of their healthcare. But on the flip side, people, I think it was a few years ago, Facebook had more than 1 billion transactions a month on people posting their health information. Hey, look at this picture. Hey, I had cancer. Hey, I've got communicable disease. And people have no problem posting that, not realizing that Facebook owns that data. And, you know, I think on the flip side, when you see some of the stuff that was going on with sharing data that was going on between Google and Ascension earlier this year, it created such an uproar when people realized, despite, trust me, you know, all of this stuff is compliant. Yep. People get real, very, very sensitive about that. So we have to be very careful how we communicate, how we use, and just keep people in mind when you go using it. And again, a lot of that is just think about it ahead of time. It's just like if you're rolling out a CMR system, Salesforce, you know, ask the salesperson, hey, how long will it take to install this? Who all needs to own it? And what are all the pieces? Because oftentimes we just think you turn it on and it's that simple. And, you know, where I work now, I've seen a lot of applications sitting in the box for a couple of years because people are intimidated because they don't realize how much work is involved in making these things operationalized. So I think that's really important. Think about it up front.
Thank you, Greg, Walter, Sheetal. Thank you, everybody, for staying on a little bit past, providing some what I'll call bonus minutes in this webinar. We're really excited that you guys stuck around with us, and we're trying to do everything that we can to bring a high caliber of information that you can use in your daily practice, reaching out, engaging, and helping to restore confidence in your markets. So on top of that, we're going to go ahead and end it here. But on Friday, on LinkedIn Live, we'll have Dr. John Glaser, who is currently a co-lead of digital innovation at Harvard Medical School. He's been the chief information officer at Partners Healthcare in the past, and has also been the CEO of Siemens Healthcare. So he's got a lot of information to share. He recently wrote an article about the future of electronic health records and how they need to transfer from a transaction/billing oriented system to a system that's oriented around something that I plagiarized, intelligence. So we'll be talking about intelligence-oriented systems within healthcare with John Glaser on Friday, if you are able to make it. So thank you again, everybody, and hope you have a lovely Tuesday.
Thank you. Be safe.
Thanks, Chris.
And practice social distancing.
Yes, and wear a mask.
Please. Thank you.